I am Dr. Anupam here, and I am present here with the second class of hyponatremia. In the first class, we discussed about the sodium and water balance in the body and how to reach a differential diagnosis starting from hyponatremia. In this class, we will discuss how to treat or how to approach towards treatment of hyponatremia and what are the things we have to take care of, what are the preventive measures or precautionary measures we have to look forward while treating a patient with hyponatremia. Let's straight get into it. Treatment of hyponatremia. So before going to the treatment of hyponatremia, we have to clear two very useful concepts. That is the concept of osmolarity and tonicity. Now what is osmolarity? Osmolarity can be defined from our chemistry books is the amount of solute or the concentration of solute or the number of solutes per unit mass of solvent, right? So what is osmolality? Concentration of solute per unit mass of solvent, correct? So it can be simplified as effective osmoles plus ineffective osmoles. Now what are these factors? Now consider two compartments separated by a semi-permeable membrane, right? So there will be some substance in one compartment which can cross freely from one side to another side using the semi-permeable membrane, and there will be some substance which cannot cross freely. Those substances which cannot cross freely are called effective osmoles. So these cannot cross freely. And what is ineffective osmoles? Which can cross freely, right? So those substances which cannot cross freely, they decides the tonicity of that compartment, right? So what is tonicity? We can define it as those substance which decides the osmotic gradient between two compartments, right? Now what is the formula for serum osmolality? Is equal to 2 into sodium, this we have discussed in our last class, plus glucose by 1.8 plus urea by 2.8, right? Glucose by 18, sorry. Sodium is the effective osmole. So that is the reason why it decides the tonicity of a solution or a compartment. And urea and glucose, these are ineffective osmoles. These can cross freely between membranes. Although these contributes to the osmolarity of the solution, but they do not contribute to the tonicity of the solution, right? So tonicity is only decided by the substance which cannot cross the membrane. In our case, it is sodium because sodium is rich in the extracellular fluid. So it is the effective osmole in the extracellular fluid which cannot cross the cell membrane to go inside a cell. So it maintains the tonicity of the extracellular fluid, correct? So now what happened, now we'll discuss what happens when there is hyponatremia, correct? For example, this is one cellular structure. In this we have different cells, and these are intracellular fluid, ICF, and outside there is ECF. Now in the outside we have sodium, right? Because sodium is there outside, it cannot cross freely to the inside of the cell, so it maintains the tonicity and there is a balance. Now what happens when there is hyponatremia? Now we have 5 cells, right? Now sodium is reduced. Let's say we have very few sodium left, right? Now what will happen? This solution is now hypertonic because there is less sodium, and inside of the cell become more hypertonic in comparison to the outside of the cell. So now to maintain the balance, what will happen? The water from outside will go inside to try to balance, because inside the cell when it become dilute, then the concentration both inside and outside will become equal, right? So water will go inside. Now when water goes inside, what will happen? The cells will swell, right? Now the cells will become like this, okay? And there is few sodiums. So these are called cell swelling. And when it happens in brain, what will happen? It can lead to cerebral edema. So the symptoms of hyponatremia are mainly neurological, because when the cells in the brain, they swell up and there is no place to go for them, and there will be plethora of neurological symptoms. So those symptoms can be divided into 2 parts. One will be non-severe. It all comes from here. Non-severe, and another is severe. In the severe we have seizure, coma, neurogenic, pulmonary edema. Non-severe we can have hiccup, confusion, then you can have agitation, can have drowsiness, right? Delirium, right? So now what will be our approach to treatment? Whenever there is a diagnosis of hyponatremia, we have to divide it into 3 parts, right? For me, I'll first divide it into acute or chronic. And chronic is defined as more than 48 hours of duration, and acute is defined as less than 48 hours, right? Then there will be severity: mild, moderate, severe. Now you will find this in different book, a sodium from this level to this level, that level to that level, and for me it does not hold any significance, so I do not consider this. And third is the important thing, that is whether it is symptomatic or asymptomatic, right? Because if it is symptomatic, then whatever be the level of sodium in the blood, it is severe. If it is asymptomatic, whatever be the level of sodium in the blood, it will be non-severe, right? And why acute and chronic is important? Because if you try to correct chronic, acutely, then we can have what we call as central pontine myelinolysis or osmotic demyelination syndrome. Right? So we have to be very careful while treating with chronic hyponatremia. Okay? The slower we treat it, the better it is. So next we'll discuss about the treatment. So we'll divide it into acute, chronic, symptom plus, symptom minus. When I say symptom plus, that means patient is either having coma, seizure, or sodium is less than 110, right? So whenever the patient is symptomatic, that means it is coma or seizing or sodium is very low, we have to give 3% saline, right? I'll suggest another thing. For chronic, you take only coma and seizure. If sodium is less than 110 also, if patient is not seizing or not in a comatose condition, do not give 3% inertial, right? And otherwise, what is the treatment? If there is no symptom, IV fluid or fluid restriction, depending upon what is the cause. Same here, IV fluid or fluid restriction, depending upon what is the cause. So is the treatment. Now target. When the patient is symptomatic, symptom plus, then give 3% saline at the rate of 2 to 3 ml per kg per hour. Check sodium every 2 hours and target sodium increase 2 to 3 milliequivalent in the first 1 to 2 hours, not more than that. And when the seizure or the coma state of the patient improves or symptomatically patient improves, it is at that time you stop 3% and the target for whole day, target for 24 hours will be at max 8 to 10 milliequivalent per 24 hours. And this is how the target will be. This is one of the, or another, you can give a bolus of 100 to 150 ml, then check sodium, right? Problem when we give 3% saline to a patient and you try to cure it very quickly, what is the problem? The problem, as you have discussed here, if you treat it acutely, then there will be CPM, central pontine myelinolysis. Why this happens? Because at 24-hour duration, the cell environment become adapted or acclimatized to new tonicity. So at that time, if you want to change things drastically, then there will be problem, and those problems are called CPM and ODS. However, if it is less than 48 hours, you can treat it acutely, because the cell do not get chance to adapt to the new environment. So here we have an option to treat it acutely, but if it is more than 48 hours, we have to be very careful. But how to prevent overcorrection? How to predict or prevent overcorrection and in turn prevent CPM or ODS. So first we'll discuss what are the risk factors. The first risk factor will be patient who is having chronic hyponatremia and you want to treat it acutely. This is one of the risk factors. This should not be done. Right. Second risk factor will be we have a reversible cause of hyponatremia, and the most common will be hypovolemic hyponatremia, because hypovolemia can be corrected acutely. So this can cause a rise in sodium abruptly and can cause ODS. Second will be SIADH, which is caused by transient factors. For example, in a post-op patient, pain or nausea, right? And third thing will be patient who has a decreased potassium also, cirrhotic also, and patient who is having malnutrition, alcoholism. These are all risk factors. So always remember, when an alcoholic patient who is malnourished came with a history of vomiting, and there is the very high chance of getting into CPM or ODS, because they have all the risk factor. At the same time, they have a reversible cause of hypovolemia, and the hyponatremia is developed chronically. So you have to be very careful. Now what happens? Let us go deep inside this. Whenever there is hypovolemia, as you have discussed in the first class, what that will do? That will secrete AVF from the posterior pituitary. That will cause retention of water via urine, and that will cause hyponatremia. Right? Now what happens when you treat the hypovolemia? You give fluid to the patient. Right? Now what will happen? It will shut down the AVP. Right? When you shut down the AVP, what will happen? There will be free water excretion. And when there will be free water excretion, the sodium will correct acutely. Right? So now how to diagnose it? So whenever such kind of patient comes and you are treating them with fluid, always keep an eye on the urine output. If the urine output starts increasing, then you suspect it can go to rapid correction of hyponatremia. At the same time, because we have to check sodium every 2 hours. These are the two of the indicator apart from the clinical indicator. From history and physical examination, you got a point that this patient can develop ODS or CPM. Then you give them fluid, you check the urine output, check sodium every 2 hours. Now how to fix it? Fixing is very simple. We can, because it is inhibiting the AVP, we can supply AVP from outside, give AVP from outside, that is called desmopressin. If urine output is increased, there is free water excretion, you can provide extra free water. Right? 5% dextrose or PO free water. By doing this, what will it do? The free water excretion will not be accelerated and the sodium change will not be very rapid. Right? So these things we have to take care. Now how much to give, these all you can get in the online calculators, but these are the concepts that you have to understand. So today we have discussed in the beginning the concept of osmolality and tonicity. What happens when there is hyponatremia in the brain cells, and the symptoms when there is cell swelling or cerebral edema in hyponatremia. What are the severe symptoms, what are the non-severe symptoms, how to classify hyponatremia, symptomatic, asymptomatic, acute or chronic. Treatment we have decided, If it is symptomatic, give 3% NaCl, whatever be the reason. If it is asymptomatic, you can give IV fluid or you can fluid restrict the patient depending upon the cause. How to give in the first few hours, right? So here your target will be abatement of symptoms also. These two target. Then we have discussed about how to predict or prevent overcorrection like CPM and ODS, and how to, if there is a rapid overcorrection, how to treat it. And this is treatment and management of hyponatremia. Thank you very much.